is.
Well, good morning. Good morning, all. Good morning, and welcome to Medical Grand Rounds. Glad to see so many faces, many familiar here this morning. In terms of announcements, Dr. Sancy Leachman of OHSU will be presenting next week on the topic War on Melanoma. Please be sure to join us next week. Today, I'll provide brief introductions to a face who is a favorite and familiar one to many of us, Dr. Miles Hassell. His shout out. His internal medicine practice, the Comprehensive Risk Reduction Clinic, emphasizes evidence-based nutritional lifestyle management in the context of a thorough traditional medical model. Dr. Hassell earned his medical degree from University of Western Australia and then came to do his internal medicine residency with us here at Providence St. Vincent. He is also co-author of Good Food, Great Medicine, a wonderful guide and resource about using diet and lifestyle to improve health. Many of you know that Dr. Hassell is generous with his time and his teaching, reaching out to the community, the region, and certainly our own internal medicine residency program. He is wonderful about collaboration, and on that note, I'm delighted to also introduce Shelley Johnson from the Providence Women's Clinic, who will be helping share some of their work and outcomes incorporating the work of Dr. Hassell. So, good morning.
Thank you. So we're going to be talking about diabetes reversal. I was recently speaking at a conference in Hawaii, and the endocrinologist there actually refused to consider the term diabetes reversal as being appropriate to use. And so this is a recent paper where they talk about the type 2 diabetes has been identified as an incurable disease based on traditional methods of treatment. But given the state of evidence for type 2 diabetes reversal, healthcare providers need to be educated on reversal options. And I think there's considerable data that says that type 2 diabetes reversal should be considered as a very rational option for patients. When we just briefly remind ourselves of what we already know about the associations between disease and that swirl that we might call obesity and insulin resistance and type 2 diabetes, from greater mortality to more cancer and worse cancer outcomes, to all the macrovascular disease and microvascular disease complications, the association with depression, more aggressive osteoarthritis. It goes on and on. This is a metabolic disease for which treating blood sugar, I would submit, is a modest response for something that demands more than a modest response. This is a paper I keep in my exam rooms to remind people of why I'm fundamentally not too concerned about their blood sugar and concerned about their stroke risk. If we look at this square here, you can see so the vertical is a log scale looking at stroke risk, and on the horizontal is your glycosylated hemoglobins for this population. It's for the ERIC population. And showing this fairly sharp rise in stroke risk starting from the high 5s in hemoglobin A1C, reminding us that type 2 diabetes is an arbitrary diagnosis. It doesn't really have strong medical basis in terms of the risk. In other words, the patients are at substantial risk of diabetes-related complications before they have the type 2 diagnosis formally. When we look at it from the patient's perspective, they've got if we're seeing this as a pharmaceutical deficiency, which often my patients report to me that's often the way that they're treated in other clinics, is that they've got a drug deficiency, not a lifestyle deficiency. And so for them, they've got this issue of medication nuisance and cost. Especially with the higher deductibles that we've seen in the last 10 years. They've got the medication side effects. They've got all the nuisance of being a patient with diabetes, doctor's visits, lab tests, and the issues regarding home blood glucose testing if they're doing that. They're wringing their hands over whether they should get a CGM, insulin pumps, all these kinds of things, that if we have a way of reversing the disease process, makes their life a lot easier. Then there's, of course, there's the cost. In 2017, estimated over $300 billion, which is more than my pocket change. And then,
Can you make sure everyone can hear you?
can everybody hear me back there? How are we doing back there? I think I'm seeing thumbs up. If I could see, of course. Let me try that. No, that's worse. And when we look at the pharmaceuticals, we can talk about their costs, which are already mentioned, side effects, which are not trivial. But more importantly, are they effectively treating the underlying problem of insulin resistance, which is what most of our patients are being, their disease process is being driven by? And do they reflect a greater interest in treating their blood sugars or, for example, treating their stroke risk, their cancer outcomes, and so on? If we look at microvascular endpoints, we certainly see that with more aggressive pharmaceutical control, you get an improvement over conventional management. This is UKBDS data. But given that that the endpoints they're looking at, we would prefer to have down here, this is a pretty modest benefit. This is not something to celebrate. 25% reduction in retinopathy. You've got great corpses with bad eyes. Excuse me, you've got corpses with good eyes, is what I was trying to say. And shouldn't we be telling our patients, you know what? Let's see if we can aim for microvascular endpoints down right around 0 or close to it. But I don't think most of our patients are being shown this kind of data. When they're told, hey, these medicines are of benefit, I don't think they're often told what a modest benefit it is. For macrovascular outcomes, the best agents appear to be the newer ones, GLP-1s and SGLT2s. And you can see even there, the degree of benefit appears to be primarily in those who have established atherosclerotic disease. And once again, pretty modest compared to the fact that these patients are often at 5, 10, 15 times normal risk for cardiovascular complications. At least my partner, Dave, was saying that at least I look entirely anti-drug. I should mention that the herbal medicine, metformin, people often don't appreciate that it was an extract from French lilac. And has been described since 1922. Does seem to be beneficial for people with type 2 diabetes, at least those who have atherosclerotic disease. So if we're looking for alternatives to pharmaceutical management and this concept of reversing type 2 diabetes and insulin resistance, what have we got? We've got bariatric surgery and we've got lifestyle change. I won't spend a lot of time on bariatric surgery because from my worldview, it's kind of like using a sledgehammer on a hazelnut. It certainly works, but you're sort of frowning and saying, huh? Why? And so that's my view on bariatric surgery. More importantly than my view is the fact that in terms of HbA1c improvements, compared to lifestyle change, it's pretty modest. And you're thinking, these patients that used lifestyle change to achieve these HbA1c results surely went through a lot less than the patients that had bariatric surgery. And of course, as an internist, the bariatric surgery patients that we see the most are the ones with complications. So we see the skewed population of people who have not done really well, which doesn't help our attitude towards the whole thing. Just a couple of studies on diabetes reversal in randomized controlled trials. This is a fairly recently published group of papers from the DIRECT group in Britain, where they use a very low-calorie diet for 3 to 5 months, then normal diet, and look at the results. And at 1 year, 86% who lost 33 pounds or more maintained a greater than 1 year remission of type 2 diabetes. And they just published 2-year data showing that group, those that lost 15 kilos or 33 pounds, 70% of them maintained diabetes reversal. They've also published data showing beta cell recovery, and that's, I think, important for us all to realize what resilient things the human bodies are, and to not write off anything, including beta cells. And I think it's easy for people to just shrug and say, well, this patient's got a burned out pancreas. Maybe they don't. We have a couple of interesting cases right now that we're working with. They're both guys in their 70s who are pretty active, eat pretty well, more healthy than average. with blood sugars have been shown to be climbing over the last 5 years. Excuse me, I'm going back 10 years ago. Blood sugars started gradually rising. HbA1cs, we started checking them even though they were very low risk of type 2 diabetes. HbA1cs in the middle sixes. And insulin levels of 0. So we said, what happens if we reduce their refined carbohydrate intake? In actual fact, both of these guys are maintaining HbA1cs from the high 5s to the low 6s, and now for about 6 or 7 years, both of them, with no rise in their blood sugars. They still have no detectable insulin, small levels of C-peptide, and showing that they have very, very poor beta cell function, but they're able to maintain just fine as long as they keep their carbohydrates low. This is just a couple of slides demonstrating what we just talked about from the direct group. So at the end of 2 years, of the group overall, 35% reversed their diabetes from all comers. And of those that lost 15 kilos or more, that group had a 70% reversal of type 2 diabetes. Any questions up until this point? Dr. Berlin.
There seems to be an interchange between the word remission and reversal. Could you explain what your meaning is?
Oh, I would use remission and reversal as identical terms, synonymous.
So Miles, you really can't measure beta cell function by just merely measuring C-peptide or insulin levels.
No, are you familiar with how they demonstrated it?
No, how do they demonstrate it?
I didn't look into it, sorry.
No, I mean, that's typically what people do.
Yeah.
Is measure insulin, and that's really
Fair enough. So Dr. Bergstrom, would walk me through where you're thinking
well, again,
in terms of that.
Again, your cases itself, you said they had low insulin levels. Again, what you need to do is stimulate their beta cells and stuff like that. Either use IV glucose or use glucose. It's kind of like saying, that if you look at blood sugar and stuff like that, and saying, a person's fasting for 2 days and stuff like that, it's really low. They don't have diabetes.
Fair enough, but from where I'm sitting for, I'm trying to spend minimum amounts of money and not bug my patients too much, knowing that they have 0 detectable insulin on multiple assessments. At least it tells me they probably don't have great pancreas. Would you agree?
No, not necessarily. Like I said, you need to measure the sign how the beta cell functions. Again, like similar to adrenal function and stuff like that.
So would we?
Cortisol level.
Miles, I'm not sure most of the audience can hear the exchange.
Oh, okay, all right. So what Dr. Bergstrom is commenting on is that my anecdote I made about the patients with rising blood sugars who didn't have risk factors for insulin resistance and no detectable insulin was not necessarily a good marker of beta cell function. Is that a correct?
Right.
Yeah, okay.
And I think it's important in terms of if you look at this in terms of type 2 diabetes isn't just insulin resistant. So, in fact, you can have insulin resistant and not have diabetes. So, what you need to have is a loss of beta cell function.
Right. So Dr. Bergstrom's pointing out that there's more than insulin resistance, but I'm arguing that the insulin resistance is the target that we can target that we can aim for, and in so doing, help our patients be healthier.
This is exciting. Are you going to be able to show us data that there's hard outcomes? Because it's not fair to say that A1C doesn't matter and then say A1C matters.
Right, no, I won't be able to show you any hard outcomes, I'm afraid. So Dr. Leonard's saying, can we show hard outcomes that by achieving diabetes remission or a reversal, that we're going to improve outcomes? Is that correct, Dr. Leonard?
Yeah. You start off by saying that all those meds that we give are unimpressive because they're just lowering A1C.
Well, they're unimpressive because they don't lead to great outcomes. So are you arguing that not having diabetes is not necessarily a great outcome?
I don't know that it's any better.
So should we stop all our diabetes reversal programs? Should we stop all our
I just want you to be careful about totally dissing meds and saying this is the only way.
Well, at the end, let's see if it's a better way. Yeah. I agree with your comments. Yeah.
Can I follow up on her comment?
Yeah.
That's not good. In terms of the SGLT2, they're effectively even better than we see with statin therapy.
Right. But in terms of the multipliers of risk that these patients are at, it's still not bringing their risk to normal. And I'm arguing that if we can achieve ex-diabetes status for these patients, we would expect that would probably be, it'd be reasonable to, a reasonable person would say that they're going to be having fewer medical problems, that the individual, I'm going to be able to show that the individual components that allow you to reverse type 2 diabetes are also individual components that lead to better health, independent of diabetes. So I'm hoping through this that we'll be able to address the concerns that have been raised and show that we're making people healthier. We're making people spend a lot less money on drugs. We're making people have a lot less complicated lives. Now, whether that will completely reverse all the legacy risks that they might have accumulated, we don't know. And I think that's part of where Dr. Leonard's going, is how much will this actually change? But I'm pretty sure that it's going to do better than that. This was a low-calorie study. This is a project where they're using a keto diet. As with the previous diet, a lot of these programs, incidentally, are being run by commercial entities that are trying to see how they can make a ton of money off this. So this is a private company that's trying to use keto diets for reversing diabetes, and they're showing a 55% at 2 years. It's interesting that their patients are staying on a ketosis diet for 2 years. I would have a hard time doing that myself, but they're managing. There's a number of other smaller studies and some bigger studies. Look Ahead is one of the bigger studies. These studies have pretty small numbers. This is probably the closest to what we do, only 12 patients in it, but they use diet and exercise. It's curious, a lot of the studies don't use an exercise component at all. We use a Mediterranean diet approach because, first of all, if you look at the background data, the Mediterranean diet has been shown to be associated with less metabolic syndrome and less type 2 diabetes. In a couple of randomized control trials, in subgroup analysis, there is a reduction in diabetes incidence in the group on Mediterranean diet compared to low-fat diets, and this is without activity or weight loss components. So there's background data suggesting it's helpful. If we see a Mediterranean diet compared to other formal diets for diabetes management in type 2 diabetes, the Mediterranean diet seems to work better. Although it's commented that the low carb, low glycemic index and high protein, or glycemic load, I should say, and high protein diets all are helpful as well. This is Irish Shai's data from Israel, where she took a group of overweight people in Israel, and they were in a high security facility, so they were able to control these people. They couldn't leave. Apparently, she could control their diets, and so she had 3 arms: a low-fat diet arm using an Ornish model, Mediterranean diet arm, and a low-carbohydrate model using an Atkins model. And for the diabetic patients who were on the Mediterranean model, they showed the greatest improvements in fasting insulin and blood sugars. So background supportive data that suggests that this is not a bad approach to take, and we'll talk more about that later. She also showed the greatest weight loss in her group over the 2 years was in the Mediterranean diet and low-carb diet groups. It always impresses me that in the hands of an expert, a well-funded expert with a captive population, they still only got about 10 pounds of weight loss over 2 years on average. The other issues with whole food Mediterranean diets is that it's the only large-scale diet that's been studied on a large scale that's shown really broad improvements over just about every disease process, from depression to cancer to heart disease and stroke. So it's probably got the most evidence for broad health benefits of any dietary approach. It's got the good evidence with regard to diabetes we just mentioned. For most patients, I think it's easier to adopt. It's really not that much different than a normal diet compared to, say, a keto diet or a very low-fat diet or a very calorie-restricted diet. And most of the Mediterranean diet studies are actually ad lib diets. These are not portion control diets in most cases. So the investigators often comment that it's easier to achieve adherence with those diets. And this is my own personal opinion, it's less likely to promote food neurosis. I don't know about, maybe it's just Portland. But people are always talking about their gluten-free diets and so on at parties and things. And I never hear people going on about like broccoli. So in our program, we've tried to identify everything that's associated with reversing insulin resistance. So exercise, Mediterranean diet, whole foods made at home, extra virgin olive oil, raw nuts, fish, greens, probiotic foods, beans, legumes, whole grains, and not flour, alcohol, coffee, and tea, which somehow got mentioned twice. I do like coffee. Dark chocolate, that should have been mentioned twice. Apple cider vinegar, minimizing rapidly metabolized carbs, waist loss. And we try to emphasize to our patients that for most people, waist loss occurs in the kitchen, not the gym. It's really hard to exercise off your waistline. It can be done. Sleep, heat, even humor has been shown to be helpful. So we try to incorporate all those components. And
For those of us who like balsamic, does it have to be apple cider?
so apple cider is what we have studies for. Most balsamic vinegar has a lot of sugar added to it. That's why it tastes so good.
Yeah.
And if you spend enough time at the gym, you're fine. So the words we use are eat better, eat less, and be active. If our patients don't plan, we don't have success. If they won't minimize some of these really high-carb foods, we're in trouble. We like to lower the glycemic load and glycemic response of meals. We don't have strong evidence that that's helpful, but in terms of just patient feedback, we think that we get better results that way. That involves lots of fiber with every meal, vegetables or whole fruit with every meal and snack. We often recommend that people start the meal with a vegetable and having protein, good fat, and fiber with every meal and snack. And there's a little bit of data that says that this helps with weight loss. Portion control can be very helpful. Intermittent fasting strategies can be helpful. The activity, and we do have some data from diabetes that shows that people who exercise, take the same exercise volume but split it into multiple components seem to do better in terms of blood sugar management than people who do a single belt per day. The reason I recommend this is primarily because it's something I find preferable to do myself. So it's easier for me to sell to somebody else if it's something you do yourself. And being accountability, yes ma'am.
Do you promote the burst of exercise after each meal approach?
I suggest that. It's harder for me to promote that because it's really hard for me to do myself. But I like to point out to patients that's where the best data is. So what Fawn is saying is that pointing out that the best data is for people who exercise after every meal, and that's where you get the biggest blood sugar reductions. Is that what you're So we had 7 patients who signed up just for a diabetes reversal program. And it was a really interesting group for us to work with. Now, for those of you who are scorning such a small population, hey, I'm a small, up until recently, solo practice, okay? Give me a break. So all of these patients had diabetes for years or decades, and they had diabetic complications, including nephropathy. I should mention that our patients who reverse their diabetes generally reverse their microalbuminuria as well, which I'm hoping is a good thing. We talked about an omnivorous Mediterranean diet with them. And of those 7 patients, 1 patient faithfully showed up all through the year and did absolutely nothing. I think we were part of his social life. He was cheerful. He was interactive. He was interested. And he did nothing. Another patient was really interesting. So she lost 40 pounds, improved her HbA1c, dropped her insulin significantly, dropped a couple of other hypoglycemic drugs, and she decided not to keep at it because she'd been told that she would never get off insulin. So she said, well, I thought, she still had another 40 pounds to lose. I thought she was charging ahead and going to be successful, but that, so we sort of think of her as a success, even though technically she's not. And then the 5 patients that truly became ex-diabetic are, they all achieved less than 6.5%. Most of them had less than 6% HbA1cs persistently on no meds. And we saw lots of other benefits. Primarily, we were able to get most people off their antihypertensives. They comment on improved well-being, and one of the things that happened recently for another patient who's doing this for her diabetes is she gained about 5 pounds over Christmas. And she came in after Christmas. She said, you know, I started eating my old foods and gained 5 pounds. But she said, the thing about that I noticed the most is my depression came back. She said, I hadn't really appreciated that my depression that I originally came in for had lifted. And we hear that quite a bit. People often, after a couple of weeks, comment that their cognitive function seems to be better. And this is, we aren't leading the witness, I promise. They just say, hey, you know, I feel like I'm doing better mentally. So typically we see improved blood pressure, improved lipids, and improved kidney function, especially if we're measuring it by macroalbuminuria, dramatically fewer medications. And I think, referring back to Dr. Leonard's and Dr. Bergstrom's concerns earlier, I put a huge weight on this as a benefit. So let's pretend that we didn't actually achieve anything except this. I still think we're way ahead. The patient who, the weight loss range in this group of 7 patients was anywhere from 8 to 60 pounds. The guy who lost 60 pounds canceled his scheduled knee replacement surgery. He was a guy who was also doing rowing every day, rowing machine. And that was many years ago. And I should comment that in the last 20 years since we've been doing this, most of our patients who become ex-diabetic, who remain in follow-up, seem to stay ex-diabetic. I'm just going to use a couple of anecdotes from different age groups. So this lady we met after she had a stroke. I was on ER call. She came in with a stroke at 77 years old with diabetes, hypertension, asthma, and so on. So we talked to her about eating better and losing some weight. She lost 15 pounds. Became ex-diabetic, and I just saw her, so this is 15 years later. She's still ex-diabetic, still maintained her weight loss, and still living independently at home at 93 years old. This guy who came in, he mainly just wanted to get off insulin. He hated insulin. And 9 years later, he's still off insulin, on no hypoglycemics, on no antihypertensives, and on no lipid agents. We often see this marked rise in HDLs. This guy, he was in his 50s when we started working with him. We actually didn't work with him directly. He used our materials. But he's somebody whose doctor just sent him to a diabetes educator. Diabetes educator said, you know what, you might be able to not have diabetes despite your insulin. And so he lost a bunch of weight, became ex-diabetic, and we had follow-up for him out to, I think, 4 or 5 years. We don't have any follow-up since then, where he stayed ex-diabetic. And I think it'd be a mistake to say that he isn't better off being ex-diabetic than being on insulin. And this is another case that we never had any direct contact with, just used our materials. Saw Elizabeth Pockart, one of our diabetes educators at the time. Lost 100 pounds in 6 months. That's what being 100 pounds overweight and having a couple of kids that you want to be able to be a dad to. And has maintained diabetes reversal at 3 years. He's a patient of Michael Goodwin's at Bridgeport, and so Mike started him on conventional therapies, but said, hey, you might be able to do better. Go see the diabetes educator and see what happens. Once again, for those concerned that we're overstating our case for diabetes reversal, it's really hard, I think, for a reasonable person not to think that he's better off with diabetes reversal, despite all the questions we have, than staying on half a dozen meds. So the health goal priorities for our patients with type 2 diabetes should, first of all, be improve health and long-term outcomes. I think it's really hard to see people who are overweight losing their diabetes without losing their waist. And then we talk about reversing diabetes as the least important of our, this is the most important. And now I'm going to hand over to Shelley, who's going to talk about just her work with gestational diabetes. While she's setting up, any questions? Fawn.
So I see several subsets of patients. I mean, I see patients who come in who don't really even seem ready to entertain the thought of a major lifestyle change. Maybe they're at the pre-contemplative stage for all sorts of reasons, genetic, society. Maybe I'm not giving them enough education. I see patients who are willing and excited to go this route, and then I see a subset who do really well long term, and I see a subset who do well for a while, and they kind of slip back into their old ways. And those that slip back into their old ways often have a lot of guilt associated with it. They know that the program can work, but for whatever reason, they just can't stick with it. Do you see those subsets yourself as well? And do you have any thoughts on predicting who's going to end up where and what we can do to keep more people on a good path? I fully agree that less medicine is better.
So Dr. Wolf is talking about the fact that we got these subsets of patients, some like the first patient I mentioned in our group of 7 who just did nothing, some who don't even show up again, who are totally disinterested, and some who are gangbusters and go for it. And I'm afraid I don't know, like my little old lady from Nicaragua, is LOL an acceptable term? I would not have expected her to be one of our blinding successes over the last 15 years. So I've lost the ability to detect who's going to be successful and who's not. The people obviously who, and one of the things we start with is we talk to people is, what do you want life to look like in 5 and 10 years? Because my argument is our patients who can picture life in 5 and 10 years are the one, and actively pursue a better life in 5 or 10 years. We think that those are the people that we can help.
I totally
Does
agree.
that?
No, I totally agree. It's just, it's hard to, I don't know, it's hard to make it work continuously.
Oh yeah,
I don't know who that's on.
I think all of us struggle with that, and I'm sure it's partly all of our fault. One of the aspects to that that we've also noticed over the years is that patients, we might have seen a patient 10 years ago and not seen them again, and then they show up last year, I think this happened a couple of times, and said, you know what, I talked to you 10 years ago about this, I'm ready now. And then they may or may not be successful that time. I've had patients who've done that several times, and each time dropped out. I've got a guy we just saw, and each time he comes in and says, this is it, I'm ready. And then I don't see him again for another 2 years. Dr. Bergstrom.
It's a couple comments and stuff. I think, again, as I alluded to earlier, is that type 2 diabetes leads to a functional loss, so they become type 1 functional. And I think it was my patient that was in the group itself who left the program. After being in the program for, I guess, close to a year, and lost all that weight and everything like that. And despite dropping her medication, and for instance, her hemoglobin A1C were increased. I think I forget that education over, but she's not. The other thing that I think you mentioned too, is there was a big study called Look Ahead, that was sponsored by the NIH, again, looking at terms of diet and reimbursement and stuff. And again, it failed. So it failed to generate accurate terminated early.
True. The problem with the Look Ahead studies, first of all, they did get a 10% diabetes reversal rate with no improvement in outcomes. They were using a lot of weird foods, and this was a heavy commercial. This was not a whole food approach. So Look Ahead, I think, is a damning example of how not to approach this.
Well, again, it was
That's why I mentioned it.
sponsored study again, where using the best methods itself. For weight loss.
But it wasn't a whole food study. It wasn't using methods. So I'm arguing that the methods we're talking about are the methods that have been shown to two things. One is reduce insulin resistance, and 2, associate better health outcomes. That's what that list is there for. So for example, we use exercise not because it reduces insulin resistance solely. We know that people who exercise every day do better in terms of health overall. And so I think that was a big mistake of the Look Ahead study, is they weren't using, the actual techniques they were using were not techniques associated with better health outcomes. It was a weight loss study.
Yeah, I think even if they have any kind of weight loss itself, again, it will lead to improvements. It will lead to improvements in terms of blood pressure. It will lead to improvements in cholesterol. And as you say, they feel better with themselves. And I think it's been demonstrated other things. University used to have a program in terms of a right diet, and they achieved great success. And again, it's just pure carbohydrates. But again, the problem is that if you look at these patients over the long term, they'll regret.
Well, I've been doing this for 28 years, Dr. Bergstrom, and I would argue most of them don't regress. Some do.
I've been doing this for 30 years.
But you haven't been using a whole food made. I mean, we could have a two-part conference here, Dr. Cohen.
Well, I've been practicing for 90 years. That's not what my question is about. Miles, what do you recommend, assuming I think we all would agree that weight loss, blood pressure, etc., are all good things. What do you recommend in the management of patients who have significant physical disability, which for all intents and purposes precludes any significant exercise? Obesity, hypertension, hyperlipidemia, rising hemoglobin A1C. We face this all the time, and we do not have a good solution except to try to talk to people. What's your advice for the disabled?
So Dr. Cohen is wondering how we handle especially physical activity in the disabled. Can we do that at the end? Because that'll give Shelley, because Shelley needs to give her part of the presentation, and it'll fit into the end, our final slides. Shelley.
Hi, I'm Shelley Johnson from Providence Women's Clinics. I'm the nurse quality supervisor there. And I'll just tell you a little bit about how we took simple Mediterranean pattern of eating principles and applied them in our clinic. We haven't added an exercise component yet. You'll see exercise classes at Providence Women's Clinics in 2020, but this is just purely Mediterranean principles. So I'm glad Dr. Hassell spoke about the financial and time costs for diabetes, because gestational diabetes sees those multiplied. The first one is women enter pregnancy with a plan. They're making a movie of this event, and they have the birth of their dreams in mind. Also, women are the primary healthcare shopper. They get to choose where they have their baby. And when they have a good experience, they say, Harold, you should have your heart stuff done at Providence. I had such a good time. So there's a bit of a time cost for gestational diabetes. Now, with home blood glucose testing, we're asking a newly pregnant mom who's got a busy life, is working, may have other children, to test her blood sugar 4 times a day, fasting and 2 hours after meals. I haven't yet met a pregnant woman who eats 3 meals a day and takes a break in between. It's more like kind of eating all day. So this is very tough to achieve. Also, there are medication side effects. We're moving toward the first line of treatment for gestational diabetes being insulin. They're not doing oral antiglycemics much anymore, except just by exception. Women who get started on insulin often say, no one told me it would make me feel like this. I'm headachy, I'm tired, I'm gaining weight. So there are side effects for mom and baby. Newborns don't do as well when they're born to insulin-dependent moms. Also, the cost of a high-risk pregnancy. Once a mom becomes gestational diabetic, she all of a sudden is entering a really expensive 9 months. Actually, usually there are 2 months left, but all of a sudden her OB office is sending her to subspecialists for twice-weekly testing, including monitoring, ultrasounds. And if you've ever had a pregnancy before, you understand typically, ultrasounds fall out of the global package, and those are self-pay, which increases the cost of the maternity bundle of care, which increases the cost of all of our insurance. So this shifts. The average cost of pregnancy is shifting, which means for women who've had a hysterectomy, you have a maternity plan too, and you're paying for it too. About 50% of our patients are on Medicaid, state-funded health insurance, and their ultrasounds are covered. So this increases the cost of care for everybody. Also, there are burdens placed on the newborn. Newborns born to moms who have gestational diabetes spend more time in the NICU away from mom. We're testing their blood sugars frequently. Now, we don't test healthy newborns' blood sugars, but I'm guessing they might be out of range too. But we're not testing them, so we're not doing anything about it. But we certainly are testing and intervening with these new babes, and when their blood sugars don't respond, we give them formula. There are outcomes throughout childhood of babies born to moms who have gestational diabetes, which means that as the incidence of gestational diabetes is rising, our society is getting sicker and more expensive to care for. So the nurses at Providence Women's Clinic felt like we were surrounded by insulin. The doctor would say, "Nurse, go in and do insulin teaching on that patient. Her diabetes is no longer diet controlled." And we felt like that was happening pretty often. So we'd walk in the room and say, "I'm Nurse Shelley. I hear we're going to start insulin today. Tell me about what you're eating." And the mom would say, "No one's ever asked me that." So the nurses just shook their heads and say, "Why are we not asking people what they're eating until we're giving them insulin?" So we said, we just feel like this is happening all the time. So we looked at the data, and in 2018, we found that 36.3% of our diabetics ended up needing insulin, ended up developing A2 GDM, or insulin-dependent GDM. And we thought, we can do better than that. So we made this little poster, and I was told to change the title from diabetes prevention and reversal to just diabetes prevention because people have different opinions about reversal. So I suggested, well, call it remission, call it reversal, call it sustained normal A1Cs without medication intervention, but reversal is shorter. Call it whatever you want. So we took off the title and changed it to prevention, and then I put it back on for today. So we thought we could, with weekly nutrition groups, teach patients about simple Mediterranean principles of eating, and over a year would be able to reverse the percentage of our patients who developed insulin-dependent type gestational diabetes. And my medical director said, "Oh, that's so sweet. Diabetes is an interesting beast. You won't move the needle on diabetes. You may have some luck with anemia, but go ahead and try it out." So we just got our numbers back from 2019, and in 2019, 20.7% of our diabetics needed insulin. So we actually did clear the 10%. I think it has a lot to do with infusing the food into the clinic and the culture, and I also think it has a lot to do with us going into those insulin teaching visits and saying, "Hey, Dr. Drake, can I have the last chance conversation with her? Like, he wants you to start insulin, but if your next blood sugar is normal, do we have to start insulin? No. What can we do about this? What can we do about dinner tonight? What can we do about breakfast tomorrow? Now, with your next high blood sugar, we got to make that phone call and do this insulin thing, but you've got one last chance." And I think it works, because they had a motivator before, the baby growing inside them. This is why I'm in this field. I get to go back in time when women are young, healthy for the most part, and motivated by bringing a little human into the world. So that's why I have a lot of hope. So we called our program The Green Pregnancy. It's Portland. People liked it. They cook breakfast with us, and the women get in there and crack the eggs and cook, and so they're going home with skills. So the patients who participated in the Green Pregnancy ended up with no gestational diabetes, no fetal birth injury. For those of you who delivered a big old fat diabetic baby with the shoulders. Their average hemoglobin at delivery was 12.0. We actually had some success talking with vegans about how vegan diets can end up not turning out so well in terms of Alzheimer's, Parkinson's. There's just not enough fat to get to the brain, and how they don't turn out well with iron deficiency anemia. And a lot of them were open to the suggestion of adding some things to their chili as long as it was ground up. They did not end up with IV iron. We're seeing a whole lot more anemia. I mean, iron is the most abundant mineral on the earth, yet iron deficiency anemia is one of the most common illnesses. And a lot of women are going in for IV iron toward the end of pregnancy. That's expensive, and it's high risk, and it happens in the hospital. So none of those patients that participated needed IV iron, keeping in mind that these people had one dose of a cooking group where they talked about nutrition with other moms. We didn't talk about exercise. It was just purely Mediterranean principles. Babies did not spend time in the NICU, and they, after filling out a survey, they had improved confidence cooking at home. And with the studies about cooking at home, we know that it really doesn't matter what you're cooking. As long as you're cooking at home, you're doing better than those who aren't. So overall, this is how our clinic is doing. The blue line is our overall patient population. About 14.7% of them were anemic in 2019, 0 in the green pregnancy group. With gestational diabetes, we were higher than I thought. We were at about 21% of our patients developed gestational diabetes, 0 in the green pregnancy group. And then A2 GDM, those who needed medication management, right under 5%, and 0 for the green pregnancy group. C-sections, we had, I I think 2 patients who went into the green pregnancy group already expecting to have a repeat C-section, so that threw off our data a little bit, but we had fewer than the general population. Grace, I talked with yesterday. She agreed to let me share her picture today. She said doing the nutrition group early set a level of consciousness that was there through my entire pregnancy. Grace had a family history of gestational diabetes. She was Pacific Islander, had a strong family history of type 2 diabetes. She did not develop gestational diabetes. Baby was not admitted to the NICU. She went home from the hospital earlier than the average person does. There was no birth injury. She had an intact perineum. And our senior medical director, who allowed me to try this thing out, ended up assisting as the placenta came out. And so she was pleased with the outcome. But again, with the diabetes prevention and reversal, my manager even said, I wouldn't say that word because people don't like it. And I said, well, aren't we all hoping that gestational diabetes reverses itself after delivery and after that load is taken off the pancreas and she recovers? Aren't we hoping she's not type 2 diabetic? Aren't we kind of all hoping for that same thing? Because 45% of our patients with gestational diabetes end up with type 2 diabetes in the first 5 years. So what is it saying for our society? So anyway, basic Mediterranean principles. It's working in the maternity unit where life begins.
Thank you, Shelley. I'm going to just go back to our slide of the actual elements that reverse insulin resistance, if I can find it back here somewhere. I'd just like to remind you that when you're, and this is something for Dr. Bergstrom was bringing up the Look Ahead study, this is the kind of thing they don't do. So what we're focusing on is not weight loss. Weight loss is an important component. But what we're focusing on in terms of our interventions have been shown to be associated with better health. And that's, I think, a really important aspect to this, even things like dark chocolate. Because we're not just focusing on insulin resistance, we're not just focusing on weight loss, we're not just focusing on blood sugar control, we're focusing on better health. And having said that, let's go past. And so Shelley, I'm hearing that you didn't see any NICU admissions, any need for IV iron, any gestational diabetes in your group.
Right.
That seems like a big deal to me. Is it being perceived as a big deal? Is it as big a deal as it sounds like to me, and is it being perceived as a big deal in your unit?
Well, Dr. Hassell, it's a big deal for me because I'll answer your question so people can hear. It's a big deal for me because my nurses are more engaged because they see the effect of their investment. They want to show up at work and read more articles on the best approach. They are more connected to patients. They're more likely to call them and follow up if they've cooked in the kitchen with them, I'm finding. What I was hoping is that just a sample of patients who volunteered, these are people who were interested anyway. We didn't randomize them. We just invited everyone, and this is who showed up. So I was hoping we could have a sample of the already interested to demonstrate to other patients next year, hey, look what happened last year. If you weren't interested before, perhaps you'd be interested now. So it's a big deal to me. I think it's a big deal for the cost of care in general. And I haven't shared the data with my senior medical director yet, but I'm getting together a few things I want to ask for first. And I think it'll go well. Mm-hmm.
And let me guess, would there be less burnout among nurses who do this kind of thing?
It's
would that be
interesting.
a reasonable speculation?
We've tracked employee sick calls throughout this program because we started with cooking breakfast in the clinic in our break room, and this happened on Friday mornings. And for some reason, there was always a sick call from the medical assistant's front desk and a nurse on Friday. And when we started cooking on Fridays, they started showing up more. It's interesting. Yeah.
Thank you.
Thank you.
So there's a lot of, the point I was making here is there's a lot of indirect benefits from what we're doing that go beyond blood sugar, go beyond weight loss, and go beyond the issue of insulin resistance, including cancer. And when we have the studies that have looked at the Mediterranean diet approaches, it's quite striking the reductions in cancer incidence that we see. If you look at the data overall, this is Nurses Health study data, physicians follow-up study data. So 120,000 people followed for somewhere in the region of 30 years, and found that these basic principles dramatically increase length of life, reducing diabetes, reducing cancer, reducing heart disease, reducing stroke. Obviously, all this is best accomplished before the patient gets diabetes. So we would argue that what we should be looking for is that 30-year-old with the first sign of insulin resistance. In our practice, most commonly, they're a little chubby and they've got hypertension. They don't have an antihypertensive deficiency. They've got a vegetable deficiency in most cases. This is nurse health study data as well, where they found that people who had the diagnosis of diabetes, if they went back and looked at this, they had this huge population to work with. In this case, they were doing 120,000 people, 20-year follow-up. Those that developed type 2 diabetes, at the time of their diagnosis, if they went back and looked at their pre-diabetic data, 15 years before they had the diagnosis of diabetes, their risk of cardiovascular disease had already gone up by between 2 and 3 times. One of the things we're addressing, of course, in doing all this is we're addressing the individual elements of the metabolic syndrome. So waistline, blood sugar, blood pressure, HDL, and triglycerides. All of those shift with this strategy. And with the more of those elements you get, the higher your risk of cardiovascular disease on the vertical axis. So I often say to people, so you've got 3 of the elements of the metabolic syndrome. Your waistline's a little bit big, your blood sugar is a little high, even though it's not high enough to be diabetes, you're hypertensive, or you've got high triglycerides or something. Your risk of stroke is already 4 to 8 times normal. So I put you on an antihypertensive, and I drop your risk by 30%. Oh, great. Now your risk is only maybe 5 times normal. How's that feel? How about instead losing 20 pounds? And that's how the strategy, at which point they leave and find a different doctor. I would argue that not having type 2 diabetes or prediabetes is ideal, that pharmaceutical management is second best, that there are multiple collateral benefits independent of blood sugar if we reduce insulin resistance, even if we aren't successful in reducing diabetes and reversing diabetes completely. For those of us that are trying to do this, we have to solve these problems ourselves. If you're a busy professional and you haven't figured out how to exercise, you're probably not going to be able to help somebody else figure out how to exercise. Celebrating success. I'm always amazed when our patients, drop $10,000 or $20,000 worth of drugs per year, and their insurance company doesn't send them a gold star or a Snickers bar or something. So diabetes is an enormous preventable, personal and medical and social and economic burden for the most part. We can identify risk factors early, we can do something about it, and I think we could do a better job of structuring an effective type 2 diabetes and insulin resistance reversal pathway. We play around with the term tough track, because this is not easy, and we wouldn't want to think that it was ever suggested it's easy. Basecamp has a class that we do in April. It'll be a 4-part class if you have patients interested in this kind of approach over at Basecamp, and you register through the Providence Resource Line. So I'm going to answer Dr. Cohan's question about exercise and the disabled. We use something called a body blade quite a bit. Anybody here familiar with the body blade by any chance? Okay, we got one. Okay. So body blade was, I believe it was initially designed for wheelchair athletes and that kind of thing. But it's just it's a fiberglass rod that people shake, and you can do just half a dozen different, probably more than half a dozen elements with it. So it's a really good upper body exercise that almost never injures people. We use a lot of like medicine ball kind of stuff, resistance bands. So there's a number of things that can be done for the wheelchair patient, which we work with. Shelley.
I saw in one of the Canadian guidelines stress reduction as a key component, and could you speak to that a little bit as part of lifestyle modification? So
the idea of stress reduction, we've never seen any outcomes data independent of activity and stuff. So we fondly like to think that if you're spending time chopping vegetables and talking to your family and going for walks, that you're going to reduce your stress. But this would be a weak point for us. I don't think we've got a great stress reduction package except better life. So I apologize, I can't answer that better. It's fun.
What role do you see public health programs playing in this? Do you think they're necessary?
Oh, I think if we could, I don't think they're likely. Remember, there's no money in this effectively. Given that I can't even see any interest in the insurance companies in this. I mean, the insurance companies are paying the 5, 10, 15, 20. I've got one lady, she uses $1,000 worth of Lantus a month. She's one that's totally disinterested in change. She says it's, and I can't remember how much out of pocket it is, but it's substantial for her. And you'd think the insurance companies and the public health people, at least we could be starting pilots. I don't quite know how to scale this, but even if, say in the Look Ahead trial, for example, they had a 10% diabetes reversal rate. Even if we only got that for a $300 billion a year industry, you'd think that that would be a good start. So even if most of us out there who do this, remember patients have been doing this on their own, depending on how you characterize this. You could argue that the treatise on corpulence from 1850, which was a bestseller in London in 1850 for 1 shilling, you could say that it was probably the first written material along these lines of reducing insulin resistance, back before there was any diabetes, of course. But humans have been doing this for themselves without any help from their physicians forever. As long as we've had diabetes, type 2 diabetes, people have been said, I probably need to get more exercise and eat a little bit better and maybe exercise. So that none of this is new or revolutionary. What would be revolutionary is if the medical profession said, you know what, not having diabetes is almost certainly better than having drug-treated diabetes. Let's figure out how we can take those patients like Shelley did, who are interested in this, and help them achieve this. Can everybody do this? No. Can a whole lot of people do this? Sure looks like it to us. Claudia.
So if you can't get the insurance companies, I'm wondering if you can actually, Providence St. Joe's is huge now, and we're all doing our Virgin Pulse to get our, healthcare set-aside dollars. Why don't you talk to them and say, hey, if people came to 2 of my classes, they could get 500 points or whatever.
Yeah, some people do get that from our classes already.
Oh, okay.
Yeah. So, Shelley.
I have an answer to the public health question. What can the public health arena do? I've written my share of letters to WIC. In pregnancy, they'll cover certain things. They'll cover cereals, flour, rice. They cover low-fat dairy. So when I talk to my moms about low-fat dairy, they'll say, well, yeah, WIC gives me, fat-free milk and low-fat yogurt and diet salad dressing, but they won't cover the full fat. So educating WIC about the outcomes for full-fat dairy. There was a study just out about 0 to 5-year-olds who drink full-fat milk instead of 1% have closer to ideal BMI at 5 years old, better blood pressure.
And bigger smiles.
And when you're talking about abnormal blood pressures in 5-year-olds, then we know our society has a problem. So that's one area where public health could improve.
But I don't know how to get into the power structures, because boy, there's a lot of money in this.
Yes, you talked a lot about what you eat is very important, but what about the question of when you eat and why you eat? Are you recording data on that? Because you alluded to the intermittent fasting diet and exercising after eating. Have you been able to accumulate data to give us an opinion of whether these things are important?
No, remember I'm a solo practice. There is no funding for what I do, except from my patients. So we do not collect data on when people eat. We do collect data on whether they're losing weight or not. And if they're not losing weight, we poke them in the tummy and say they need to eat less. And then we talk about how to eat less. We call it the Michelin Man test. So there's 2 ways of eating less. One is to have smaller servings, and the other is to do something like intermittent fasting, which certainly is an effective tool. So we don't really care how people eat less as long as they eat less. That wasn't a very helpful question for the way you're thinking, but that's the best I can do, I'm afraid. Dr. Ironside.
B. Williams, take her name down. She's an editorial journalist for the Wall Street Journal, lives in England. How We Eat. Buy her book, read it. It's all about this whole program, and she's got statistics for Europe, the United States, the world, how we eat is going right down the tubes. It's a fabulous book. Her name is B. Williams. She is a fabulous writer.
Thank you.
So I have a friend who's a retired doctor he practiced at Kaiser. And several years ago,
I'm sorry.
you talk about insurance plans don't help you. But several years ago, he was diagnosed with early pre-diabetes, and Kaiser put him they have a program which giving information, direction on care, close follow-up, calls with him, special scales that transmit his weight electronically. And I saw him recently, he talked again about it. He lost about 30 pounds, fasting glucose, A1C, all normal.
And this is part of their program, so they're very big into preventive care. So how do you compare what you're doing with what you're doing at Kaiser?
Well, we're talking about diabetes reversal, because we have I'm correct that somebody here that can speak to the fact that we have a diabetes prevention program, don't we? Yeah. Yeah. So what I'm referring to, because the diabetes prevention programs I think are almost everywhere with various levels of success. But we're talking about reversal.
Now, we had abnormal A1C and abnormal fasting glucose normalized with...
Oh, excuse me, I'm sorry.
Weight
Yeah.
loss, diet, and
No,
cooking.
no, good. And if all we did was take our reversal programs, our prevention programs, and call them prevention and reversal programs, it'd be the same thing. Yeah, so I completely agree. No, that's good.
I think we're at 9 o'clock, so I think maybe some people will need to move on with their day. Feel free to engage in more interesting conversation. Yeah.
Thank you, everybody. Thanks, Shelley.
Why she said I'm
Not solar practice anymore.
No worries, my friend.